Hello, we're here at the American Heart Association meeting in Chicago, where circulation has 19 simultaneous publications this year. And that is a huge increase from 6 in the past to 19, all thanks to the man next to me. But first, let me introduce myself. I'm Dr. Carolyn Lam. I'm Associate Editor from the National Heart Center and Duke National University of Singapore, and I'm the voice you hear on Circulation on the Run. But I'm so pleased to be here in person today with Dr. Dharam Kumbhani, and he's Associate Editor from UT Southwestern, and he also leads the simultaneous publications for this journal. So big applause for this amazing bonanza this year.
Thank you.
Next to him, we have Dr. Sana Al-Khatib, and she's from the Duke University. And finally, Dr. Gabriel Steg from University of Paris. Wow, okay, we've got 19 papers to chat about. No, I'm just kidding. We're gonna talk and focus on the 7 simultaneous publications that were late-breaking science. Why don't you start us off, Dharam? We will first start with the interventional trials, and there were 3 of them. I'd love you to chat about the first of them, but even before that, maybe tell us what it's like to get a simultaneous publication, because I think people underestimate the amount of work it takes to do that.
Yeah, no, thanks a lot, Carolyn. I think, under Joe's leadership, the whole space of simultaneous publications and late-breaking clinical science has really been, it's been a big endeavor for him and for the journal. And we just have an amazing team that's able to work on this, in very quick order. So I think, for the viewers, I think, it's a very involved process, but it's a very gratifying process. Mm-hmm. We work very, closely among the associate editors, the senior editors, and then the Circ staff, and we have very rapid turnaround time. So we owe a lot of gratitude to our reviewers, who frequently will turn these reviews in within 48 hours. And our goal has been that we respond back with a decision usually within 5 to 7 days. Yeah. And so, so it's been very gratifying, then it moves on to next set of revisions, et cetera. But even among the papers that we're unable to, accept for circulation, it's just a quick turnaround time for the author, so they haven't lost as much time and, can potentially look elsewhere. So it's been a really gratifying process. It's been a great team effort. I appreciate, everything you said, but really I don't deserve all that credit. It's been a great team effort.
No, it's been rumored there's a lot of lost sleep on your end. So thank you, Dharam, for this. And maybe you could open with the ISAR test 4. That's one of the intervention.
Well, thank you. I think, we had some really interesting interventional trials, and, Dr. Steg will discuss a couple of them as well. I think ISAR test 4 was a very interesting trial. It is one of the first stent trials that gets to the 10-year mark. So, this is just the 10-year follow-up results of that. We know, it was about a 2,500 patient trial. It was done in Germany, multiple centers. And really they were trying to assess the space that they were trying to, or the knowledge gap that they were trying to fill was, the durability of the bioabsorbable polymer stents. And so specifically they were looking at a bioabsorbable polymer sirolimus-eluting stent, the Yukon stent, and then they compared that with durable polymer stents, including Xience, or the everolimus-eluting stent, and then Cypher, which is no longer available in the US, but that's a permanent polymer sirolimus-eluting stent. So, the primary results, published and presented a long time ago, there was really MACE events at 1 year, and it showed non-inferiority for this bioabsorbable polymer stent back then. So then they had, incredibly 83% of the cohort that they were able to follow up out to 10 years. And, what they showed is that, and we can, I don't want to necessarily get into the numbers and the details as much, but what they showed is that this bioabsorbable polymer sirolimus-eluting stent had tended to have similar outcomes to Xience, which we, accept as state-of-the-art current generation stent, permanent polymer. And it did better than the Cypher stent, both in terms of MACE events and stent thrombosis. So suggesting that the big advance in the field for this is this is a long-term follow-up of this stent. It suggests that outcomes may be similar in this patient population, although only 12% were really enrolled with an MI in this patient population. Most of them were stable or less sick ACS patients. And they show, fairly good outcomes out to 10 years, comparable to Xience, and better than Cypher. So I think it was interesting. Gabriel, what is your take?
No, I think it's important. There's been a tremendous interest in the interventional community on trying to tease out which are the best types of stents, and beyond brands, try to understand the type of stent, the coating, the drug that you put on it, whether the polymer is durable or not durable, and I think these types of fairly well done, large randomized trials with long-term follow-up are critical. And a lot of the focus in the interventional community originally was on lumen size, late loss, angiographic parameters, short-term. And now the field has matured and we've moved to clinical outcomes, patient-oriented outcomes, long-term follow-up. And it's important because we've learned from long-term trials such as PROTECT that the result at 1 year may not predict what happens at 5 years, and sometimes you have surprises. So it's really important. We owe it to our patients because these are irretrievable devices. Once you've implanted them, they're there. We talked about Cypher being out of the market, but there are more than 1 million patients who walk every day on this planet with a Cypher in their coronary arteries. So we better know what the long-term follow-up is.
Yeah, that's a great point.
Wow, thanks also for the discussion that allows me as a non-interventionist to realize, it's hard to keep track of what's happening with all the different types of stents and polymers and so on. But could you then summarize for the field, does that mean that these biodegradable ones are now, do I sound ignorant when I say that, but that they're now, really in the game? Is that what it does?
So, there's this whole bioabsorbable field, there are nuances. So this really is testing a bioabsorbable polymer with every stent, you have a stent, you have the polymer, and then you have the drug.
Thank you.
And so the polymer and the drug go away, and then you're left behind with the bare metal stent, and that's this Yukon stent.
Got it.
The one that has been in the press a lot more is the bioabsorbable scaffold, where the stent and the polymer and the drug, everything in theory should be gone at a certain period of time. So this is, it's an important distinction though, because I know that, it's very confusing. You just say bioabsorbable, and it's unclear if you're talking about the polymer, you're talking about the stent itself, but this really was a bioabsorbable polymer issue. So you're left behind with the bare metal stent at the end of it.
Got it. Crystal clear, and thank you. That's cool. That's super.
For an electrophysiologist, too.
But now let's go into the AMI field, right? So there were 2 trials that really spoke to acute management patients coming in with an AMI and with cardiogenic shock, for example. So Gabriel, could you tell us a little bit about the IABP Shock 2 trial, as well as the, really talked about door to unload impeller trial?
So the IABP2 trial is a randomized trial, looking at the benefit or lack thereof of intra-aortic balloon pump in patients with cardiogenic shock and acute MI. And it's been standard practice since the 60s to offer IABP pumping to patients with cardiogenic shock and AMI. So literally more than 1 million patients have been implanted with IABP. But the reality is when we look at the randomized trial evidence of benefit, there was none. There were very small trials, inconclusive, underpowered, and Professor Thiel from Germany and his colleagues deserve enormous credit for having had the courage to really do what needed to be done, a proper randomized controlled trial, of course open label. And what they found in IABP2, which they already reported a few years ago, is that there was no acute benefit of IABP on survival, short-term, nor for that matter on many of the secondary clinical outcomes looked at in that trial. They subsequently reported 1-year mortality. What they did here is they gathered follow-up on almost all of the cohort at more than 6 years. And they found that the long-term survival is identical for patients who received an IABP and those who did not. So I think this nails the issue. But there's another thing we learn. The mortality at 6 years is staggering. It's close to 60%. And although a large fraction of the patients die in the first 30 days, you still have an additional 10% of patients who die between the first year and 6 years. So it still remains a very sick patient population for whom we need to investigate new strategies. And I don't think it's going to be necessarily mechanical. We have to think of all of the strategies we can do to prevent and mitigate cardiogenic shock to build up. And that gets us to the second trial that I'll talk to about.
Can I ask you a quick question though about this? Did they provide any information about modes of death in these patients?
Yes, they did capture information about that. Off the top of my head, I'm unable to provide information, but yes, they did capture that. The German system allows them to retrieve information about causes of death, and it's a closed system. It's a national trial, so they were able to get
because this information
enormous
can
follow-up.
help us inform like what interventions are needed next.
Yes, that's really important.
Yeah. And to your point about that it's you use the very interesting word last nail. That's actually also how Dr. Hockman addresses her editorial, which she wrote a really nice.
The leading expert in the field.
And so I'm interested in your thoughts. So the use of balloon pumps for shock, there's a discrepancy between the American guidelines and the European guidelines. Last year the European guidelines were updated, and it is really such a practice-changing guideline in that this routine use of balloon pumps and cardiogenic shock is a class 3 indication, which is as going through training, that was all you had when someone comes in shock. You would throw in a balloon pump, and so it's that's really quite a practice-changing event.
Yeah, so these investigators are embarking on new studies with ECMO, and I think it's going to be fascinating to see whether ECMO, which also gets increasingly used worldwide, whether there's evidence to actually support or not, whether this is useful. So I think they are doing the proper thing, they're doing the right thing, randomized trials, and we should commend them because these are really difficult trials. In the acute MI setting, shock patients, ECMO, IABP, that's really difficult. And they are brave investigators, they're good investigators, and I think they provided the community with a clear answer.
And exactly the kind of papers that we like publishing at Circulation, isn't it? Now, what about the door to unload, though?
So, there's actually a good segue with door to unload, because if we can't properly treat shock once it's there, can we do something to prevent shock? Can we do something to preserve myocardium? And one of the experimental findings that is very clear is that if you unload in experimental myocardial infarction, if you unload the left ventricle, you reduce infarct size. And so investigators have been trying to translate this experimental finding into the clinical arena using the Impella device. And there's enormous interest, particularly in North America, for Impella use in acute MI patients with larger infarcts, with the idea that if you can unload the left ventricle, you might be able to mitigate the extensive myocardial infarction and therefore avoid cardiogenic shock and probably improve prognosis. Although this is a very attractive theoretical concept, it still deserves to be tested. And so if you want to test it, you have to unload the ventricle as soon as possible, ideally before reperfusion, which means that you're going to have to delay reperfusion for the time of implanting the device and unloading the ventricle. And so what the investigator did in this trial is to study whether delaying purposely by 30 minutes reperfusion to unload the ventricle for 30 minutes prior to reperfusion was feasible and reasonably safe. And it's a small trial, it's really a pilot trial. By no means does it test the proof of concept of the device or the theoretical issue, but it shows that it's feasible. There doesn't seem to be a massive increase in the total time to reperfusion, because just by chance, the group that was not delayed had a longer time to PCI, so eventually things are sort of evening out. They looked at MRI size of infarcts at follow-up. There was no obvious difference, but of course it could still be type 2 error, so we're not totally sure about this. But certainly it paves the way for doing a proper proof of concept randomized trial, testing unloading versus no unloading with a true control group. And I think that's what investigators are looking forward. But I understand there's immense interest for this concept in the interventional community, particularly in the United States, and I'm quite curious to see what this future trial will look like and what the results will be.
Yeah, indeed. So Gabriel, I noticed you were very careful to frame it, to say what the trial was trying to address and what it wasn't. And there's been quite a lot of buzz after that. Do you agree with everything Gabriel said, and what have you heard? And
yeah, no, I think, he was, incredibly eloquent in, kind of outlining the premise of the trial and what it really showed. I think the one thing that, and this was brought up in the very nice editorial by Dr. Patel from Duke as well, is, that it would have been really nice to have a control arm which didn't have any unloading, because these are not patients with shock, that just directly had primary PCI, and then comparing infarct size. So I think that was one of the pieces of information that would have been helpful to then put this in perspective. So when you have an infarct size of 8% or 10%, how does that compare in the same patient population that they're testing? But it's you're absolutely right about the need to do difficult trials like this, where a lot of times it's just assumed to be true and is embraced in clinical practice. And as I gave the example about the balloon pump earlier, where as a fellow, you saw someone in shock, and your reflex was to put in a balloon pump. And so I think testing this, very difficult patient scenarios, as well as just in terms of trial execution, we're really, it's amazing to have 2 trials on that.
If I may come back to this, it's funny because we've been using the IABP for years, thinking this is what we should do in shock. Now, our German colleagues have proven IABP doesn't work. So a lot of investigators have reverted saying, well, we should use Impella. But where is the evidence showing that Impella is beneficial?
Right.
We have none, so I think that's a trial that deserves
and
to be
ECMO,
done as well.
yeah, exactly, yeah.
Exactly. And, going back to door to unload, it's important to prove safety in order to go to the next step,
Yes.
which is
No, I think
exactly
it
how you
shouldn't be
framed it, and that's how
overinterpreted.
it should be exactly received by the community. So that's great. Now let's switch gears a bit, Sana. So
Yes.
in EP world, the EP-guided non-invasive radioablation of VT. Fascinating stuff. What were your thoughts?
Oh, I absolutely agree, definitely. So this was a phase 2 study that the authors did. They enrolled 19 patients, so it was a small study. But it was really helpful. Remember, there's a major clinical need there. These are patients who have an ICD, who have recurrent ventricular tachycardia. They've been treated with at least 1 antiarrhythmic medication, at least 1 catheter ablation procedure. And then what do you do with those patients? This is actually a clinical scenario that comes up frequently, and we absolutely need to be looking for more therapies for those patients. So that's what that study was about, is trying to explore new ways to treat these patients. And to be able to do it non-invasively, I think is fascinating. And so that's what they enrolled these patients. Patients had to have failed these treatments, antiarrhythmic medications, prior catheter ablation, and they underwent non-invasive imaging to really localize the source of the ventricular tachycardia, where it's coming from, and then they subjected them to stereotactic body radiotherapy to ablate those sources of ventricular tachycardia. And of course, the results were fascinating because they showed on the effectiveness side that this seemed to be very effective. Because if you look at the reduction in the burden of ventricular tachycardia, and a couple of their patients actually had significant PVCs and PVC-induced cardiomyopathy, there was a significant reduction in the rates of these arrhythmias in these patients with this intervention, which was great to see. In fact, to be specific, about 94% of these patients, so 18 out of the 19, had significant benefit. And in about 89% of the patients, there was more than 75% reduction in the arrhythmia. So these are actually really interesting findings, especially in a patient population where we really don't have other options. Now, of course, you're going to ask me about the safety. What are the safety concerns? Of course, this was a primary endpoint for the authors. They did look at safety up to 90 days, and they found that there were 2 significant adverse events that occurred in those 90 days. One was heart failure and one was pericarditis. The concern, of course, with radiation is what else can we expect, especially if you follow the patients longer. So certainly we need more data. The authors acknowledged that beautifully. And I think their intent is to launch a multi-center randomized clinical trial, or maybe, I don't know if it will be randomized, but at least a multi-center clinical trial to see if they can replicate those findings. So that was very interesting to see.
Yeah, it was. So thanks, that was really exciting. So some exciting trials in my world of cardiometabolic disease too. And I want to highlight 2, the Carmelina trial and the Camellia TIMI 61. So first, the Carmelina trial. Now, this was a secondary analysis of Carmelina. And this was, Carmelina, if I can remind everyone, is a cardiovascular outcomes trial, randomizing about 7,000 patients with type 2 diabetes and atherosclerotic cardiovascular disease and or chronic kidney disease, and randomizing them to the DPP-4 inhibitor, linagliptin, 5 milligrams a day versus placebo, following up for a median of about 2 years. So we know that type 2 diabetic patients are at risk of heart failure, And there's always been a bit of a question mark when it comes to DPP-4 inhibitors and their risk for heart failure. And so this secondary analysis looks specifically at the hospitalization for heart failure and related events in Carmelina. The important thing is that all these were prospectively, centrally adjudicated events, and this was a pre-specified, though post hoc analysis. And the summary of it all is that linagliptin was not associated with an increased risk of hospitalization for heart failure or the composite of cardiovascular death and hospitalization or the related outcomes. And importantly, the authors did also sensitivity analyses and interaction analyses to show the results were consistent whether or not patients had a history of heart failure, which was in 27% of patients, regardless of the baseline ejection fraction that was measured within a year of starting the drug, and also regardless of renal function, so eGFR or urinary albumin to creatinine ratio. So this is really important because this trial adds to the growing, perhaps, understanding of DPP-4 inhibitor heart failure risk. The whole question mark actually came with SAVOR-TIMI, and that was sexagliptin. But since then, there's been 3 of other trials that have shown no heart failure risk, Examine, TCOS, and now Carmelina. So an important addition, and I think should reassure us. And then from diabetes and heart failure risk, which is always very hot, but now obesity. So the Camellia-TIMI 61 trial looked at renal outcomes in this trial. Now, what was this trial? It was actually testing lorcaserin, and that is a selective serotonin 2C receptor agonist in about 12,000 obese or overweight patients. Basically, the primary results showed that it did not increase any, it met its CV safety outcomes with weight loss and so on. But this time they looked at renal outcomes because obesity has been known to be associated with hyperfiltration of the kidneys. You get albuminuria and it's apparently worsening of kidney disease. So we need to know, is pharmacological weight loss going to be associated with improved renal outcomes? And basically that is what Camellia-TIMI 61 showed. Their renal outcomes was new or persistent albuminuria, and then the standard doubling of eGFR or end-stage renal failure, renal transplant, or renal death, and that was improved by lorcaserin. Along with that, there was the anticipated reduction in weight, HbA1c, and BP. So it does look like from these late-breaking results, right, that we have another tool in our toolbox.
And for the clinicians out there, like which patients should they be thinking to use this medication in? Like what kind of obesity are we talking about? At what point do you introduce that?
Yeah, so this is common garden, just defined by BMI that was above 27. And I don't think they're saying to use it in patients with renal dysfunction, but to sort of say that to look and see whether weight loss also associates with renal function and improvement, and it does. So it's reassuring. Yeah. And then, okay, let's round up with that last trial, right? And very interesting one because it's pragmatic, mobile health, and wellness. Tell us.
Yeah, it's really a monumental effort. So this is, I'll be brief, but it's really a phenomenal trial from an epi standpoint and implementation standpoint. So this is from India. It was, coordinated by the Center for Chronic Disease Control and the Public Health Foundation of India, where, as everyone knows, India is now the diabetes capital of the world, and chronic diseases have very quickly overtaken, other infectious causes as a number 1 cause of mortality and morbidity. So this was a, big undertaking, really collaboration from 3 continents, where, but it was a community-based cluster randomized trial. They had 40 community health centers, and what they were trying to see is primarily for hypertension and diabetes, that if you implemented a structure and typically using this mWellCare tool, which is basically an electronic medical records storage facility, and then it also has inbuilt clinical decision support, and really for hypertension and diabetes management, but also they had tobacco, alcohol screening, abuse screening, and also for depression. And so what they really wanted to do is, very ingenious endeavor, and they tried to see if doing this systematically on a cluster randomized fashion, if that would actually influence patient outcomes. So they had a little over 3,000 patients, and they followed them for 12 months. Unfortunately, the trial itself, as far as the primary endpoint, which was change in systolic blood pressure and hemoglobin A1C, they had pretty significant reductions in both arms, about 12 to 13 millimeters, which is amazing from a population health standpoint, in both arms, not statistically significant, and in hemoglobin A1C, also by 0.5% in both arms. And just suggesting that kind of having this more frequent interactions with the medical health system itself was driving a lot of this benefit. So although the trial itself was negative for the primary endpoint, I think it's a huge step forward for the management of chronic disease epidemiology and burden in developing countries.
Neutral.
Ah, true.
Fair point. Fair point.
But we've discussed this whole array of 7 trials, and they are difficult trials. I mean, talk about another difficult type of trial to do, cluster randomized pragmatic trial.
Sure.
It's amazing the breadth of simultaneous publications we've had this year. Thanks again to everyone for introducing this, and thank you for joining us today.